Hello friends, in this series of chest X-ray, we will see our part 3, that is pleural radiology. In this part, we will discuss about pleural effusion, pneumothorax, pleural calcification, pleural thickening, and pleural mass. So let's see pleural anatomy. So we all know there are two pleura. One is vessel, which is attached to lung surface, and one is pedal pleura, which is attached to rib case. Okay, so it is 3D structure, means pleura is there all over, anteriorly, posteriorly, and inferiorly, superiorly, all everywhere. This is 3D view. So the pleura, especially pedal pleura, which is attached to cervical area, it's called cervical pleura. The pleura which is attached to rib cage, that is costal pleura. The pleura which is there inferior of that is basal area, attached to diaphragm, that is called diaphragmatic pleura. And the pleura which is attached to medial surface, that is mediastinum, that is mediastinal pleura. So these four type of pleura which is covering lung from anywhere, from everywhere, anterior, posterior, everywhere. So this is like a cavity inside the lungs, outside the pleura, is covering whole lungs. Okay, so this is lungs and this is pleura. So it is covering. So normally pleural cavity is empty. Only 5 to 10 ml fluid is there, which is used for lubrication, for smoothing, inspiration and expiration. So if you see this diagram, so you can appreciate this is anterior part and here is posterior and this is lateral part. So diaphragm is like this one. So this is anterior, this is posterior. Okay. So posterior part is downwards, means deepened. So this is very deepened, posterior part. Okay. Then lateral part is little shallower as compared to posterior pleural cavity. And anterior one is more shallow. Okay. So if there is little fluid, where it will accumulate in posterior recess or posterior side of pleural cavity, because posterior side is like deepest one. If pleural effusion is more, then it will accumulate in lateral side, that is costophrenic angle, CP angle. If pleural effusion is more than that, then we can appreciate in anterior part of pleura. Okay, so this is 3D diagram of pleural cavity. So what are the various pleural diseases we are going to discuss? We are going to discuss about pleural effusion, pleural thickening, pleural mass, air in pleural cavity. If air and fluid both are there, it's called hydropneumothorax, and pleural calcification. So if we see about pleural effusion, so what is pleural effusion? There is abnormal collection of fluid inside the pleural cavity. Usually 5 to 10 ml fluid is there. If it accumulate more than that, it's called pleural effusion. So pleural effusion can be free fluid, subpulmonic collection, loculated pleural effusion of, or it is there fluid in fissures. So we will discuss one by one. So if there is free fluid collection in pleural cavity, it is called pleural effusion. Okay, so how it will look like? As I discussed in previous X-ray, wherever water collection, it will give radio opacity in chest X-ray. So X-ray will looks like a white. Okay, so you can see here it is black, normal. Here it is become white color. So this is pleural effusion or fluid collection in pleural cavity. So we can have homogeneous radio opacity in the area costophrenic sulcus with higher level laterality. Okay. So if you see this X-ray, so this is outer is petal pleura, inner is vessel pleura. If there is fluid collection between these two layers, so how fluid will get collected? It will collect like this. So lateral part will go up above as compared to medial part. Okay. So it will create a curve. like this curve. So this is called Ellis S curve. This is S-like. This is Ellis S curve. This is favorite questions for examiner. Okay. So if fluid is there more than 500 ml, so we can demonstrate clinically by percussion, palpation, auscultation, etc. If fluid is there 300 ml or above, then only we can appreciate on chest X-ray. Chest X-ray, PAV or APV. If fluid is there between 200 to 300 ml, then only it will orbitate CP angle. So for orbitation of CP angle, fluid should be at least 100 to 300 ml. Okay, then only we can appreciate orbitation of CP angle. If fluid is there less than 100 ml, we cannot appreciate on chest X-ray. For demonstration of fluid less than 100, we need ultrasound of thorax. Then only we can demonstrate smaller amount of fluid. Okay. So if you talk about quantification chest X-ray, regarding quantification, we can divide pleural effusion into minimal, mild, moderate, large, and massive. So how to divide? So if you divide normal X-ray into three compartments based on anterior ribs, as I told you, most of the X-ray we can appreciate six anterior ribs. So three compartment we can divide. So lower one third, middle one third, and above one third. So this is three compartment. Okay. So if fluid is there in lower compartment only, this is mild. If it is there in uh, middle compartment, this is moderate. If it is there in the third compartment, it is large pleural effusion. Okay. If it is more than that, means occupying almost whole hemithorax, then it is massive pleural effusion. And what is minimal pleural effusion? Just orbitating CP angle. Just orbitating CP angle. Okay, so this is minimal pleural effusion. So if we can see this X-ray, this diagram, so this is minimal pleural effusion and amount of fluid is so small, we are not able to appreciate on PA view. Why? As I told you earlier, pleural cavity is not a uniform. In posterior side, it is deepest, then lateral side, then anterior side. So if there is little amount of fluid, it will accumulate in posterior recess of pleural cavity. Okay. So in AP view, we cannot appreciate. So how can we appreciate? Either we can get ultrasound done or we can get lateral X-ray. In lateral X-ray, you can appreciate minimal pleural effusion. See, this is lateral X-ray. This is posterior side because vertebrae is there. This is anterior side. So in posterior recess, you can see orbitration of CP angle. So if there is minimal pleural effusion, you can demonstrate by having lateral X-ray. In that posterior CP angle, there will be angle orbitration. So this is minimal pleural effusion. Then moderate pleural effusion. As I told you, if it is reaching up to second compartment, so if you divide, this is first compartment, this is second, this is third. So this is reaching in second compartment. This is moderate pleural effusion. Large pleural effusion, if it is reaching up to third quadrant, then this is large pleural effusion. And what is called massive pleural effusion, when effusion is occupying almost whole hemithorax, then this is massive pleural effusion. So what are the signs of massive pleural effusion? If massive effusion is there, it means some space occupying things is there. So what will happen to mediastinum? It will push opposite side. So you can see mediastinum is shifted to opposite side. Okay, diaphragm we cannot see because there is arbitration between fluid and diaphragmatic opacity. Intercostal space, it will be widened as compared to opposite side. So this is science of massive pleural effusion. You can see, appreciate trachea. Trachea is shifted to opposite side. So this is massive pleural effusion. What is loculated pleural effusion? If there is pleural effusion, if you left untreated, there will be pocket formation because of adhesions or loculations. Okay, so fluid will be there in pockets, small pockets. Okay, see, for example, this is your pleural cavity, and the pleura will form small pockets like this. Okay, so this is loculated pleural effusion. If free fluid is there, it will collect like this. If it is loculated, it will be collected like this, usually. Okay, so the angle will be acute as compared to free fluid, which is obtuse. Okay, so this is loculated pleural effusion. The fluid is there in pockets. Now, what is subpulmonic pleural effusion? Subpulmonic, as I told you, pleura is there, which is covering whole lung surface. So pleura is there in diaphragm also. So whenever fluid collection is there between diaphragmatic pleura, okay, so this is lungs, this is diaphragm. Okay, so this is vessel pleura, which is vessel pleura which is attached to lung surface, and this is pedal pleura which is attached to diaphragm. If there's fluid collection is here, this is called subpulmonic pleural effusion. So what are the signs of subpulmonic effusion? Diaphragm will go upward as compared to opposite side. CP angle may or may not be orbitated. Just diaphragm will go outside. So we cannot differentiate whether subpulmonic effusion is there or diaphragm went up because of some phrenic nerve palsy, or if there is liver abscess which is pushing diaphragm to above side. We cannot differentiate because in every case the diaphragm will go up. So how to differentiate? We have to get ultrasound done. Then only we can differentiate. It is also called subpulmonary effusion. Matlab, subpulmonary effusion is below the pulmonary part, below the lungs. So this is subpulmonic pleural effusion. So what are the other features? If you appreciate on left side, the dome of diaphragm, the apex, you can see apex, highest peak of diaphragm is there in mid-clavicular line. Okay. But if there's subpulmonic effusion, this apex will shift to lateral side. See, right side. So if you trace diaphragm, this is diaphragm, this is apex. So apex is shifted towards lateral side. Okay. In another thing is diaphragm will go upward. I told you already. CP angle is orbitated here, but it may not be there. Okay. So by this, we can have suspicion whether subpulmonary effusion is there or not. But for confirmation, we have to go for ultrasound. So this is subpulmonary effusion. Now, fluid in fissure. Okay, it means fluid between the two pleural layer of fissure. There are two fissure in right side, oblique fissure and minor fissure. And in left side, only oblique fissure. So, as I told you, that fissure is a nothing but is layer of pleura, vessel pleura. Okay, say for example, this is lung and this is fissure. So vessel pleura is coming like that, like, and coming here, folding itself like that. So this is vessel pleura and this is also vessel pleura. Okay. Then this is petal pleura. This is vessel pleura. Okay. So in fissure, both layer are is vessel pleura. So any fluid collection between these two layers is called fluid in fissure. Okay. So this is fissure, this two layer. If there's fluid collection like this, it will give opacity like a lens, biconvex lens, like this, biconvex lens. Okay. So this is lenticular shape, bounded by vessel pleura because fissure is formed by two layers of vessel pleura. Common etiology of congestive heart failure. Whenever there is volume overload or fluid overload in the body, it can cause fluid in the fissure. It is also called pseudotumor. Pseudotumor. Why? Because it looks like a tumor or lung mass, but actual it is not. If you give diuretics or if you treat etiology, it will subside completely. That's why it is also called vanishing tumor, because it looks like a tumor, but it is getting cured by giving diuretics or treatment. Also called phantom tumor, false tumor. It's not tumor, false tumor. That's why pseudo tumor, phantom tumor are because of false tumor, and vanishing when you give treatment, it will subside. In lateral X-ray, you can see fluid is there in minor fissure. If you remember my first class, like this is major fissure and here is minor fissure. So fluid is there between two layers of minor fissure, vessel pleura. This is fluid fissure. Now coming to pneumothorax. So what is pneumothorax? There is abnormal collection of air between two layers of pleura. Normally, there is no air in pleural cavity. But if there is abnormal pleural collection, air collection, that is pneumothorax. So as I told you in beginning, in radiology and chest X-ray, the air gives a black opacity, that is translucent opacity. Fluid is giving white opacity. Okay. So if there is air, it will look jet black. Okay. Since this is air, there will be no blood vessels because in pleural cavity there is no blood vessels. So it is black. Here air is there plus blood vessels. That's why it looks black with some white. Okay. So because of pneumothorax, the air will compress the lungs. So lung will get collapse. This is collapsed lung. This is collapsed lung. Okay. So blood vessels is there intact in lungs, but lungs get collapsed. So what will happen? These blood vessels give more whitish opacity as compared to normal X-ray. So in collapsed part, the blood vessels looks more prominent. Okay. So this is features of pneumothorax. If pneumothorax is mild or moderate, it will not push mediastinum to opposite side. But it is large pneumothorax, then it will push mediastinum to opposite side. It will shift trachea opposite side. It will shift lower mediastinum to opposite side. So this is pneumothorax. What is deep sulcus sign? If patient is in lying down position, we know because of gravity, air comes up and fluid goes down. If patient is there in erect position or patient is standing position, the air will get collected in upper part. But patient is lying down part, then air will go first to inferior part. Okay. So what will happen? Inferior is CP angle. This is CP angle. So when air will go in CP angle, it will create more angular part, means it will keep deepening of CP angle. So our CP angle will looks very deep, black and deep, more prominent. Can you compare? This is right side, this is left side. So left side CP angle is very shallow, but here it is deep, deep CP angle. So this is deep sulcus sign seen in pneumothorax, which occurs in patient who is lying down or bedridden or in ICU. So if there is deep sulcus sign, you should rule out pneumothorax, especially in ICU patients. This is massive right side pneumothorax. Then you can appreciate mediastinal shift. So in this, you can see this is collapsed lung. Okay, mediastinum is shifted. You can see trachea is also shifted to opposite side. One more, and another thing is diaphragm. You can see right diaphragm usually higher than left side, but in this case, because of pneumothorax, diaphragm also pushed downwards. So diaphragm is get flattened. Another thing is intercostal space. Because of pneumothorax, there is expansion of right hemithorax. So this intercostal space also widened as compared to left side. So these are the features of massive pneumothorax. Now another important entity is tension pneumothorax. Very important. It is one of common medical emergency. If you don't know tension pneumothorax, you may lose patient in front of your eyes. So what is pneumothorax? First, we should understand how pneumothorax develops in a patient. So pneumothorax means air collection inside the pleural cavity. So air can go inside by environment, by the puncture or some stab wound or some blood wound from environment to pleural cavity, or it can come from lungs to pleural cavity. If there is some focus in lungs, the lungs will get rupture and will create connection between lungs and pleural cavity. Okay, so it will give pneumothorax. But if there is one-way communication or valve-like communication, okay, it means valve-like, one-way valve, one-way valve, one-way valve. So what will happen during inspiration? Air is coming from lungs to pleural cavity. But while exhalation or expiration, air is not coming out from pleural cavity to lungs. So what will happen? In each inspiration, air is going in pleural cavity and getting accumulated there. So pleural cavity is expanding, 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 expanding in each inspiration. Can you imagine how difficult for patient to maintain his vitals? Okay. So what will happen? The full of air in one side. So what will happen? It will push mediastinum to opposite side. And I told you in mediastinum what are the vital organ? It is heart. So mediastinum pushing from outside, lungs is pushing outside. Heart is not able to function because lungs need space for contraction, systole, diastole. But something is pushing from outside. Heart is not able to do his normal function. So what will happen? Heart is not pumping its fluid. Then what will happen? The JVP will get rise. There will be hypoperfusion of all body organs. BP will go down. Hypotension. A patient will end up in shock and patient will expire in front of your eyes. So this is medical emergency. So if you see patient, especially young patient, sudden dyspnea, increased JVP, muffled heart sound, hypotension, shock, and if you keep your steth here, you will not be able to hear breath sound. Then you should suspect pneumothorax, tension pneumothorax. And you cannot wait for X-ray. You have to treat immediately, otherwise patient will expire. So what will you do? You just put a needle, whiteboard needle, 16 gauge or 14 gauge or 18 gauge, whatever is there with you. You insert in second intercostal space mid-clavicular line. And you can observe there is gush of air which will come out from pleural cavity to environment. So this is tension pneumothorax. This is really medical emergency. Then coming to large left side hydropneumothorax means along with effusion, there is air collection. Okay. So if there is pleural effusion, we will have Ellis curve like this, Ellis curve. Okay. But if there is fluid and air, both are inside the pleural cavity, then you will have straight border. This is straight border. Okay. If it is this large left hydropneumothorax, then it will push mediastinum to opposite side. You can appreciate heart went opposite side and shifting of trachea also to opposite side. This is hydropneumothorax. Below, because of gravity, fluid will accumulate in the lower part. It will give white opacity. In our part, it will look say black because of air. So this is hydropneumothorax. In this X-ray, can you appreciate this is blunting of CP angle? Okay, and you can appreciate this is pneumothorax. Okay, this is collapsed lung. Can you appreciate collapsed lung? If you observe clearly, you can find fissure also. See, this is fissure. Anyhow, so this is right side mild hydropneumothorax. You can appreciate the straightening of fluid border. Okay, so this is hydropneumothorax. Ear upper part, fluid in lower part with straightening the border. Now coming to pleural thickening or pleural fibrosis. Whenever there is pleural effusion, the nature is so that it will heal automatically. So when pleural effusion heals, it heals by fibrosis and it will thicken the pleura. Okay. So whenever there is healing, it will be filled by fibrosis. And if there is fibrosis, it will contract the normal pleura also or underlying lungs. So what will happen if somebody is having right side pleural thickening? It will contract. So patient will have the drooping of left shoulder. Right shoulder. Okay, narrowing of intercostal pleura. Can you appreciate left side? Okay, so this is pleural thickening. So same X-ray you see after 7 months. So you can appreciate there is pleural thickening. See, this is pleural thickening. Can you see pleural thickening? And because of pleural thickening, you can compare this shoulder and this shoulder. So left side shoulder is little drooped and intercostal space narrowed. So this is pleural thickening or pleural fibrosis. If there is massive pleural thickening, as I told you, there are two pleura, parietal pleura and visceral pleura. So lung is attached with visceral pleura. So say for example, this is lungs. So here is visceral pleura and here is parietal pleura. If both pleura get thickened, what will happen? The visceral pleura which is thickened, it will not allow lung to expand. Clear? So if there is thickening of visceral pleura, lung will not be expand. It is called trapped lung. Okay. Patient will require decortication, the peeling of pleura, the different issue. So in this X-ray, if you found there is pneumothorax here and this is effusion, and you can see this is pleural border. This is visceral pleura, this is parietal pleura. So both are thickened. Can you see this is parietal pleura is thickened, this is visceral pleura. So for complete explanation, you can get CT scan done. In CT scan, you can appreciate right side is smaller than that of left side. Right side is smaller because of contracture. This is right side as compared to left side. So this is pleural thickening. And you can appreciate this is parietal pleura and this is visceral pleura. This is parietal pleura thickening. Can you see, appreciate? This is visceral pleura. This is visceral pleura. This is parietal pleura. Visceral pleura. This is visceral pleura. This is parietal pleura. So, and here it is empty space because of the vessel pleural thickening will not allow lung to expand. So in this X-ray, you can appreciate there is crowding of ribs. The intercostal space is narrowed as compared to left side, and shoulder is drooped. This is shoulder. This is drooping of shoulder on right side as compared to left side. So this is pleural thickening. Another entity is pleural calcification. So post-primary tuberculosis heals by fibrosis or thickening, but primary tuberculosis heals by calcification. So whenever there's calcification, you can think of primary tuberculosis healing by calcification. So in this X-ray, you can appreciate this is opacity. Okay. And if you can appreciate the density of opacity is same as bone. This is calcification. Okay. One more thing you can appreciate, there's drooping of left shoulder and intercostal space is narrowed as compared to opposite side. There is contraction. Okay. So if you do CT scan, then only you can appreciate pleural calcification. Can you appreciate white color? This is pleural calcification. See, whole pleural calcification on left side. So it will looks like a bone. That is pleural calcification. Now, last is pleural mass. So there are few malignancy which involve pleura. So primary malignancy is mesothelioma, and secondaries can be anything: adenocarcinoma, squamous carcinoma, anything. Okay, so you can appreciate lung parenchyma, nothing is there, but in pleura you can see this is opacity, rounded opacity. So this is pleural mass. Okay, so we did biopsy and we got diagnosis of mesothelioma. So this is pleural mass. This is rare X-rays. Okay, so that's all in pleural pathology or pleural X-ray, pleural radiology. So if you want to understand more, then you can go through my previous videos on chest X-ray. So I have discussed the technical aspect and how to read normal X-ray, and of course radiological anatomy in CT scan or chest X-ray. So you can go through it. So that's all in my this lecture. So thank you very much. See you with new video. Thank you very much.